Next, we have Dr. NAMITHA VJ. Her paper is on From In to Out, What Causes Consecutive Exotropia.
Good morning all. My presentation is on From In to Out, What Causes Consecutive Exotropia. There's no financial interest in the study. Consecutive exotropia is a manifest outward deviation developing in a formerly esotropic patient after surgical treatment for esotropia. By convention, exodeviation more than or equal to 16% diopter for distance and near is considered significant enough to intervene in case of consecutive exotropia. Based on the onset, it's divided into immediate and delayed. Immediate mainly because of a slip muscle, slip medium rectus muscle or improper suturing, and delayed cases are mainly because of stretch scar or because of late muscle slippage or because of sensory exotropia due to poor vision, amblyopia or suppression. A thorough history looking to the onset of initial squint and the primary surgery parameters along with going through the old photograms and previous discharge summary will help us in planning a proper intervention. So our aim is to evaluate the clinical features and factors responsible for the onset of consecutive exotropia in patients who underwent surgical correction for esotropia. So it's a retrospective EMR analysis for all the patients present to the pediatric ophthalmology center in a tertiary eye care center with the diagnosis of consecutive exotropia from the period 2013 to 2024. The previous surgery data is obtained from a discharge summary, serial photographs, and from the EMR. All patients underwent a detailed ophthalmic evaluation, including binocular vision status, cycloplegic retinoscopy, anterior segmented dilated fundus examination, and these were the parameters we assess in case of primary surgery, like age at the surgery, type of initial squint, angle of deviation, and the amount of medial rectus recession, and the type of surgery, whether unilateral procedure or bilateral medial rectus recession was done. In consecutive exotropia, we assess the presence of amblyopia, any presence of adduction limitation, any convergence insufficiency, any presence of pattern deviation, inferior oblique overaction, DVD. Also, we assess the position of medial rectus intraoperatively, whether there is any slip muscle or any stretch scar or all the muscle were at the intended position. And all the patient underwent exploration of medial rectus, and most of them underwent medial rectus advancement plus or minus lateral rectus recession. And those with oblique overaction, we did an inferior oblique weakening also. And those with less than 20% diopter, we advanced only one medial rectus. Those with more than or equal to more than 20 to 25, we advance either both the medial rectus or with unilateral medial rectus advancement plus ipsilateral lateral rectus weakening. Coming to the result, most of our patients were in the age group of 10 to 20 years. The mean age was 18.10 years. Females outnumbered in our study. Coming to the primary surgery parameters, 20 out of 29 patients had primary surgery elsewhere. The mean age at initial surgery was 3.77 years. Most of them had undergone surgery for infantile esotropia. 13 out of 29 patients have preoperative angle of deviation available, of which the mean angle of deviation was 40% diopter and average MR recession was 5.41 millimeter. And majority are undergone bimedial recession than unilateral resect procedure. 41% had poor follow-up. Coming to the consecutive exotropia parameters, the duration of exotropia as obtained from the parents was ranged from, the mean was 8.77 years, and the duration between the primary surgery to the consecutive exotropia was 12.91 years. The mean angle of exotropia for distance and near was almost similar. We also assessed the non-surgical parameter and the surgical parameter which would have led to the consecutive exotropia. In non-surgical parameter, 62 patients were amblio, 82 were suppressed. In refractory status, most of them were emmetro, followed by myope and hypermetropia. 20% had anisometropia, 17% had DVD, and pattern strabismus with inferior oblique overaction was present in 31%. Coming to the surgical parameters which would have led to consecutive exotropia, we have found most of them underwent a large MR recession more than 5 with an average of 5.41. and 13.79% had convergence insufficiency, 10.34% had adduction limitation, 10.34 had slip muscle, and we found that medial rectus at intraoperatively, three patients had slip muscle, one patient had a stretch scar, and rest all had a medial rectus at indented position. All the patients had underwent exploration of medial rectus, and 51.72 patients had underwent unilateral medial rectus advancement with ipsilateral lateral rectus weakening. Coming to the binocular status, 82.75% were suppressed before surgery, of which 65.5% remained suppressed even after surgery. 6 patients attained fusion. 1 patient had a transient diplopia which almost settled by 3 months. Coming to the discussion, the incidence of consecutive exotropia after ET surgery is reported to be 4 to 27% in previous study. The main risk factors for consecutive exotropia we encountered in our study are poor follow-up. It's seen in our study the mean duration of exotropia and the duration between primary and second surgeries were more than 8 years. And once the alignment is done, most of the parents forget about the frequent follow-up, and once an outdrift comes, they will come to the clinic. We also found there was large medial rectus recession in our case series, and the previous studies done by other at all, like it was more than 6 mm of medial rectus recession as the causative factor for consecutive exotropia. However, we found that even at more than 5 mm, there is high risk of consecutive exotropia. So to limit the medial rectus recession by 5 mm, and development of amblyopia is another strong factor which was seen in the other studies also, as the amblyopic eye has a tendency to outdrift. We also found that adduction limitation, which in turn can lead to a convergence insufficiency, instability of alignment, and can lead to a late exodrift. In case of missed oblique overaction or in pattern deviation, mainly in children with esotropia are examined in the primary position with a modified Krimsky test, and all the oblique overaction are measured in the vertical, in the up gaze or in the down gaze, and in such cases the pattern deviation are usually missed, and an oblique as such is an abductor, and overaction of obliques can lead to an outdrift. DVD also, because amblyopia with poor binocularity can lead to DVD, and DVD is characterized an outdrift, updrift, and extortion, which itself can lead to consecutive exotropia. The other factors are development of new refractive error and late scar remodeling. To conclude, poor follow-up, amblyopia, and large medial rectus recession more than 5 mm is a risk factor. Inferior oblique overaction, DVD, and inadequate refractive correction can also contribute for overcorrection. So, all patients undergoing esotropia surgery should undergo a periodic follow-up with proper refractive correction and amblyopia treatment to prevent the development of consecutive exotropia. Limitation data collection due to a retrospective nature and a short sample size are a limitation. These are my references. Thank you.
There were 2 patients who were more than 50 years old.
Yes, ma'am.
So, what was the cause in them?
One patient presented to us at 64 years, and she had history of an acute onset ET. That from the records it was available by 12 years she had undergone surgery, but she presented to us late.
She was
Ignored.
patient in both eyes.
She was suppressed in that eye. Strabismic amblyopia was there in that eye. And the same patient had a slipped medial rectus also, ma'am.
I think 5 mm is a bit drastic to say, because I think 6 and more you can say that, but 5 is looking at your data since your muscles had not slipped.
Only 3 patients have slipped muscle.
Yeah, so I can't blame that 5 mm medial rectus recession as your cause. Maybe amblyopia. How was there any correlation did you find with the visual acuity to consecutive exotropia? What was the mean visual acuity in patients who had
Visual acuity as such, I didn't check, ma'am. The amblyopia factors I checked that 62% were amblyope.
amblyop means? How will you say amblyop without checking the visual acuity?
Visual acuity we recorded, but into consideration.
Drips